All right. So welcome everyone. We're here to talk about emerging trends in labor and delivery models, and specifically dive into the Connecticut Children's Hospital Special Delivery Unit named the Maternal Fetal Care Center. I'm gonna So with the presenters here today, some of you, we introduced some of ourselves to some of you. Carrie May is now the global pediatric and women's health healthcare leader at Canon Design. But most recently, she came from Connecticut Children's as a senior director of facilities and planning. And she really led the project that we are going to talk about today. We also have Colette, who's also worked on Connecticut Children's, and she is a designer and planner with experience across a range of healthcare projects. She's done a lot of women's and peds, and she has interiors background, so she really brings in the experiential elements to her work. Gari Nadkarni is also a peds and healthcare subject matter expert, and she has worked on many projects across the country. Hampton Frost is is it Dallas or Houston? Hampton.
Houston.
Houston. He's a programmer planner, and he also focuses on women and peds, and has worked on many projects across the country. But I do want to say that this group is part of a larger subject matter expert group at Canon Design, and we're very collaborative, and we meet regularly, and we talk about war stories, benchmarking, and best practices. So a few of us came here today to do the presentation. Our agenda is we'll get into women's health. What is it? Just get into some environments of care. We'll get into delivery models. We'll dive into a special delivery unit, and we'll study the Connecticut Children's Hospital design and model that we're implementing now. It's under construction. And we'll open it up for questions. And I'm thinking, because we have a pretty long deck, that it might be best to type in questions at the chat and then have a discussion at the end. That's okay.
Cindy, but did you by chance get a form for the CEUs at the beginning of this before we get started?
Oh, yeah.
Yes, we did, I believe.
Can you copy paste it in the chat? Sorry.
Yes, I can do that.
Great. Thank you.
So we're going to talk about some environments of care. Colette will dive into that and why it's unique.
Yeah, perfect. Thanks, Cindy. So we wanted to first start out just really talking about women's health in general and what makes the environment unique, different from other healthcare typologies. So this is just some imagery from a few different projects we've worked on, and words you might hear typically about women's healthcare is spa-like or hospitality focused. So typically it is a little bit more of an elevated approach to healthcare, although I would add the caveat that that is typically, or it's always based on the region, the area, the demographic of the group that we're caring for, so where your project is based. A few other things that really make it unique, I think, is that you have a broad audience within that space, but the patient themselves may be going through kind of all aspects of the facility. So in a typical healthcare project, you may have surgery and then go to recovery and then go home. But within women's healthcare, you may be going to really each department within that facility. So the experience throughout the space is really important and really critical to be consistent, but also thinking about that patient all the way through the facility and the length of stay. So sometimes the length of stay can be very long. Different models of care are implemented. There are different types of spaces that you might see. So that top right image, for instance, there's a wig shop. Sometimes you'll see different types of gift shops that are really focused on women's care, but really a broad range of both spaces and focus of those spaces. So bringing in hospitality elements, bringing in different artwork, kind of elevating that experience for patients, especially as women are able to shop around for healthcare a little bit more, especially in obstetrics and gynecology, is really critical as we move forward.
All right. So women have unique healthcare needs as they advance from their adolescent years through their senior years. And in supporting that continuum of care, there are a range of women's services. So Cindy, could you just click? Yeah, thank you. So there's a range of women's services. Obstetrics and gynecology are more commonly identified with women's services, but this range is slowly expanding now to include some other unique concerns or specialities around for women. So this includes heart health, bone health, breast health, oncology, behavioral health, reconstructive surgery, urology, geriatric care, etc., to name a few. And we see these both on the outpatient as well as the inpatient side. And in fact, there has been a current trend to include all of these different services as part of a more comprehensive and integrated model, so that the care is more convenient and accessible for women. Next slide. So today we'll be focusing on obstetrics, and obstetric involves with managing the health concerns for women during pregnancy, childbirth, and postpartum. And within obstetrics, there's multiple subspecialties. We'll be focusing today only on maternal fetal medicine. And so what is maternal fetal medicine? It is essentially perinatology or MFM, and it's focused on managing the health concerns for the mother and the fetus prior to, during, and shortly after pregnancy. And what makes MFM unique is that it manages the condition for women with high risk pregnancies, and most of the times the fetus has some sort of complications. Some of our current stats suggest that 1 out of every 33 pregnancies will result in a baby with a birth defect, and that the number of women experiencing pregnancy and childbirth complications has increased by 31% almost. So with these stats, it sort of supports the increasing need for the maternal fetal medicine program, which used to be a niche program. Before we get into some more trends around the maternal fetal medicine, we wanted to sort of walk you through the evolution of maternal and fetal care over the years. So on the maternal side, before the early 20th century, home births were fairly common, and the field of obstetrics was rudimentary. There was poor hygiene, limited medical knowledge, and lack of interventions, all of which attributed to increased mortality rate in mothers. And during the early 20th century, hospital births started becoming more common, antiseptic practices around childbirth improved, and all of that slowly resulted in significant reduction in maternal mortality. During the late 20th century, this further evolved, and LDR and LDRP models were introduced. LDR is labor delivery and recovery, which it's a birthing model that allows the mother to be in the same room during the entire process of childbirth. And then LDRP is an extension to the LDR model, which allows both the mother and the baby to be in the same room during the childbirth and postpartum. So we see the focus was slowly now shifting towards a more holistic approach towards the care for mother and children. And in the recent years, we are seeing MFM and alternative birthing methods becoming more and more common. And there's more, telemedicine has become more common as well. Parents are opting more for personalized care, and there is more focus on maternal mental health and inclusivity. On the fetal side, we see a similar evolution. During the early 20th century, there was a significant reduction in the fetal mortality rate as well, and ultrasound started becoming more and more common to monitor fetal development. In the late 20th century, fetal interventions started getting introduced, which allowed physicians to perform difficult treatments, surgeries, and diagnostics on a fetus while it was still in the mother's womb. And then in the recent years, genetic counseling and testing has become more and more common, which allows the parents to find out about any genetic concerns involving their child and to hopefully diagnose that earlier so that then they can also treat those conditions earlier. And there's also an emphasis on global health initiatives for maternal and fetal health.
So while there have been tremendous advancements obviously in medical and technological advances to help support women and children, especially during pregnancy and delivery, we are seeing, of course, a decline in birth rate. So this continues to go on. I know this graph goes through 2021, but continuing into 2024, that it continues to decline. We had one slight uptick, but what we are seeing increase is the age of mothers. So you can see that 30 to 39 age range has increased, but in general, older mothers and higher complexity to both the pregnancies and to the birth itself. So you could go to the next slide. And what that looks like, so again, you're seeing here an increase up to 2032, we're looking at 39% of pregnancies being high risk. And that, again, could be on the maternal side or it could be high risk for the fetus. And so that fetal intervention category is increasing. We're seeing that both on the outpatient side as well as on the inpatient for delivery, surgical intervention, et cetera. So again, decreasing number of births, but increasing complexity, increasing use of NICU, despite that reduced birth count. So today we're going to walk you through, and you can go ahead first through the traditional delivery model. Gowrie mentioned earlier the LDRP or LDR model. So we're going to walk through what that looks like first at a high level, and then really dive deep into the SCU. So first, of course, if you go into delivery, you would first go into an OBED, so an obstetrical emergency department or a triage unit. Sometimes that occurs within the traditional emergency department. Then get moved if you have a complex issue or you need to be monitored, you may be moved into antepartum if you're not ready for delivery as a separate unit. And then as you move into the labor portion, you would go either to C-section or for vaginal delivery within the LDR or LDRP room itself. Within the LDR model, you would then move into a postpartum room with the potential of baby going with you into that room or into a well baby nursery. We're just going to walk quickly through an example of what this could look like. So here we have an OB emergency department. You could go back one slide. And here you might go into intake or admissions. They would assess you and move you into a triage or exam room, kind of used a little bit interchangeably in this example. But what you would see that's a little bit different than your traditional emergency department model is that you usually have an ensuite bathroom. It's a little bit larger room. It's often used for holding, kind of to determine if you need to go into the antepartum room or if you can be discharged and go home, or if you're ready to go into delivery. So then as you move up to the LDR floor, if you can go to the next, there we go. In this example, obviously all of these departments are really closely aligned, and that adjacency is very helpful. It's not always possible. Sometimes you'll see them across multiple floors. But in the bottom right, in the pink, you're seeing an antepartum department. So that again is where if you need to be monitored before you give birth, if you need to stay for one day up to a few weeks, even longer, potentially that you would be in this this department. These rooms are typically smaller. They're usually about the size of an acute care room, very traditional setup. But again, we need to think about that patient experience as you're moving through. From there, you would move into the labor component. So in this example, the area in yellow is that labor and delivery department. This is an LDR model, so you're not recovering in the room, but it's a much larger patient room. So you're seeing there it's about 450 square feet, much larger to accommodate an infant head wall as well as all of the activity involved in delivering a baby. If you were not having a vaginal delivery, you would be moved into either into pre-op or directly into C-section, depending on the level of emergency of the scenario. And then after C-section, moved back to the PACU, which in this instance is a shared department. And then you would move up to the next floor, if you could go to the next slide, and recover in the postpartum unit. So again, in this example, well baby is within the postpartum department. The patient room, again, about 250 square feet, so about the size of an acute care room. But the bassinet could come with you into the room or stay in the well baby unit if you want to get some sleep, or if there's an issue and you need to have someone keep an eye on baby for you. Again, this project is a unique one in that there's a NICU directly adjacent to the postpartum department. So if baby needs a little bit more intervention, they can be moved over while mom is still in postpartum. One other thing I would point out before we move on is just that the C-section rooms on the previous slide are about 500 square feet. So those are large enough. They're smaller than a subspecialized OR, but they're a little bit larger than the requirement. And that's really to be able to have multiples in there, but again, a pretty traditional setup, pretty traditional birth, just the opportunity to deliver twins if needed. And I think we can move forward, Cindy. So again, this was a traditional model to an LDR. If you had an LDRP, that would really just take out, again, that postpartum section, bring it back into the LDR room. It's typically done where you have fewer births or a smaller community. So again, traditional model. Now we're going to move into a different and unique scenario of a special delivery unit.
That's perfect. Well, and we can stay on the slide for just a second. So tying back to what Gary was talking about, where at the turn of the century, we started to see fetal intervention capabilities increase. And then also back to what Colette was talking about and the rise of the LDR, the LDRP models, which are really mother-centric and family-centric. The special delivery unit starts to tackle, what do we do about the unique fetal cases requiring that fetal intervention, which could be surgical, it could be medicine. So please go ahead to the next slide. So an SDU, right, a special delivery unit, it goes by a few terms in the industry, but one of the key components we like to identify this with in the nation is well women, compromised fetuses. So another way to say that would be healthy moms, at-risk babies, at-risk fetuses. So its focus is really honing in on the fetal cases where we're concerned about their capability to make it through delivery or their ability to maximize life potential. So we take care of high-risk fetal conditions within an SDU. It is focused on delivery, of course. These can be combined with the maternal fetal medicine outpatient clinic or independent. They typically are partnered with an adult care provider. And that's coming from, we've got a bunch of fetal specialists and experts working in this space, but they still need to bring over those adult care specialists to take care of mom. So that partnership is critical. And then lastly, again, honing back to that, we're taking care of the fetal and infant conditions. We typically are almost, I would say always, see these paired with a neonatal intensive care unit or another type of intensive care unit that focuses on newborns. And then lastly, because of all of those different components, it's not uncommon to find these within a children's hospital. Rather, that is the most common that we're seeing because of that fetal and infant focus. So this is a staggering photo for those of us who have worked on ORs or seen an OR. As Colette mentioned, a typical delivery operating room might be somewhere around 400, very small, to 600, a little bit more ample square feet. But we exceed the capabilities of the traditional delivery model when you get into special delivery units. So this room is probably closer to 800, 900 square feet for those with tracking the members here. And you could summarize it by saying there are about 3 different groups in this space. Working from the left to the right, we start with, we now have there's probably something like a 7-person care team just preparing all the different instruments that are needed to take care of mom and also baby or fetus. And then in the center, just below some of those surgical lights, we see the maternal care team. Most of these deliveries are happening through C-section. You have an anesthesiologist there, even if you're not going under general anesthesia. So we've got a bunch of experts there working on mom. And in this case, on the far right side of those 3 groups, we see the group of fetal interventionalists and also infant surgical specialists. So they're gathered around the newborn baby, working on them. You can't even see them in this case. It's not uncommon for them to be extremely small prenatal conditions, but they're dedicated to working on the baby. So with those 3 teams in the room, we need much larger spaces than a delivery model can afford. And the more we know about the patients we're treating, the better job we do. So we wanted to show this slide as these are some of the most common conditions. Congenital heart disease is probably one of our front-running factors. 1 out of even 500 cases, 1 out of every 500 typical deliveries could end up in an SDU with the ideal circumstances. Congenital diaphragmatic hernias, let's see, sacrococcygeal teratoma, spina bifida, twin transfusion syndrome, very rare, but requires a dedicated group of expertise. All of these are still these 5 groups. The most common we're seeing be admitted into an SDU. And the annotations or the pictures, they can be scary, but they show what the fetuses and the infants are having to deal with and why this type of unit is so critical. Now, thinking back to Colette just walked us through what a typical delivery model would be. You can see we've added a lot of different bubbles and circles here because the process, as she said, is going to get a little bit more complex. One of the unique aspects about an SDU is that traditionally, or I should say typically, the care need is pre-identified. During prenatal healthcare services, ultrasounds and such, most likely going to identify early on that you need to come to an SDU to deliver your at-risk child. So go ahead and advance one slide or one click, please. Perfect. So in those cases, if it was a predetermined need that is scheduled, you might go into an antepartum phase. And by the way, these are stages or phases. On the next slide, we're going to talk about how they translate to rooms. But so when you're looking at these dots or circles, think about stage. If the care need was identified, but there's an emergency situation, or the care need was not pre-identified, then the mother might be admitted into triage space. And then in particular to fetal intervention, if the care need is known and the mother is coming in for fetal surgical intervention, she'll get prepped in a certain phase of stage of care, pardon me. So from triage, focusing on those moms who come into triage, some of them might be false alarm. They get to go back home. So you can see an arrow on the bottom pointing to the left. Others, the mother may herself have complications, and this type of unit is not specialized in that. So those cases are better to shift to the adult partner we're talking about earlier. Let them take care of the mom in an environment that's dedicated to helping her out, and they'll bring the fetal care folks and specialists along as needed. If mother does need to be admitted for triage, she'll either come into antepartum or she may already be beginning the labor phase, and so she would just go into a labor phase of care. Going back to those who are getting fetal intervention. So some moms will come in, will need to perform surgical intervention on the fetus, and then sew mom back up with the fetus still in the womb and send mom home. So in those cases, surgical prep would go into surgical intervention. Mom would get sewn up. And if we go to the next slide, or next stage, thank you. You'll see the very top arrow there pointing at the far right. Mom could then be sent to surgical recovery or possibly the PACU. If she was entered into the antepartum phase, she would then proceed into labor and or directly into delivery. And next phase, great. So in the delivery, not unlike a common model, you might deliver through C-section or vaginal. However, you're probably not surprised to hear that most of these cases are going to be cesarean section. So the babies on bottom in purple, they once they are delivered, they may go into neonatal surgery if infant surgery needs to be performed, and they could then go into an intensive care unit, or straight from the delivery room, they may go right into the NICU. That's actually one of the most common scenarios that we see. A very uncommon, but it's a great news when you hear it, condition is that after cesarean section or vaginal delivery, the baby may actually get to join mom back in postpartum care. Mother out of the delivery space on the top in the blue arrows would potentially need to go into PACU type services if general anesthesia was administered and the jurisdiction or the hospital operations needed that type of unit, or she may go directly back to postpartum. Great. So now we're looking at how do those phases translate into the key spaces, beginning to talk about actual rooms. So labor, delivery, recovery, postpartum. That is our ideal, without knowing any more details, that is our ideal gold standard. As Gary was talking about earlier, and also Colette, this means that the mother and the family do not have the stress of transferring from multiple rooms with multiple environments, multiple nurses, air temperature in the room. Think of every little thing that could be a bother. They get to stay in one space. So the ideal care model, again, without knowing specific details, is always to see if we can start with an LDRP model, and that does apply to the special delivery unit. However, an SDU, because of that unique triage component, that does not warrant, because of its low volume, a specialized maternal ED or triage ED for delivery, you may decide, based on the hospital operations, that having 1 to 2 rooms that can just help assess and triage is most beneficial and best use of space. And then again, the moms can go home, or you could admit them into that LDRP room. And then a little bit more of a controversial one is a PACU, so post-anesthesia care unit. Typically, we, without knowing the details, would like to see the mother returned immediately to the LDRP room. You can, with direct one-on-one nurse supervision, recover even under general anesthesia in an LDRP room. However, some jurisdictions do require a PACU that you would need to file an exemption for if you do not want to feature this in the department. And also some hospitals are operationally considering, is it best to still have mom in a type of PACU environment for whatever reason, and then bring them back into the LDRP room. And then in our purple and blue kind of histogram there, we have our cesarean section delivery and fetal intervention operating room. So this is our key star, if you will, of the SDU. This is that 800-ish square foot. We have enough space for 2 care teams in there at a minimum, large feature of the department. And actually, while we're bringing up infant resuscitation, we can clarify that effectively all of the different operational procedures are anticipated to occur in this room. So those who have developed a delivery room before won't be surprised to see infant resuscitation. By code, we typically have to have a couple of gases dedicated to resuscitate the infant if needed. But in an SDU environment, speaking of kiddos, mine just got home, so he's coming over to show me some popcorn and sunglasses.
No.
So infant resuscitation.
It's William's ice cream.
Oh, even better. I've got ice cream. Let me excuse. Thank you. Okay. Oh, okay. I'm a lucky dad. Thank you. So infant resuscitation. Sorry, guys and gals. In this case, because the special delivery unit has so much going on in it, we've got to take care of mom after the delivery services. It really can be helpful to pull the infant out of that delivery room, even though you might have the resuscitation gases there, and instead conduct all the resuscitation and assessment services in a separate independent room. So basically, in an ideal circumstance, you've got your large delivery room, OR, I should say, with an adjacent and connected infant resuscitation room. That way the 2 teams can come in and both be dedicated, do what they need to do within their own space, and not have cross traffic. And then lastly, as Cindy advances the slide, just one click, we have, of course, a NICU, or sometimes you hear it called a SICU, but a CICU, or cardiac intensive care unit. That harkens back to the CHD condition that we're talking about, where a lot of infants or fetuses have a congenital heart disease. All right, now we're getting into where do you put the rooms? This may not be a shocker for a lot of y'all, but as we look at the top bar of dashed rectangles, we can see what departmental components of the SDU would we expect to find them in. So if we elected to have a maternal triage, and then of course the LDRP room, those are both going to be in the inpatient unit and subject to all the requirements needed for an inpatient unit. The cesarean section and fetal intervention OR, the infant resuscitation, and if you have a PACU, the maternal PACU would all be part of your perioperative suite. The NICU, SICU, of course, is its own unit. And then on this slide, you're seeing a couple of the other factors that we're going to talk about more. At the bottom row there, the maternal fetal medicine outpatient or ambulatory clinic, and then the administrative suite. And so bringing those into this slide, we're now looking at what kind of relationships and adjacencies are required. We're going to call the 3 on the right the trifecta, with the solid purple lines pointing between them. All of these really need to be adjacent and connected to each other pretty absolutely. Of course, the maternal inpatient unit and perioperative need to have an immediately directly accessible route. Mothers would come from the top one, go down to the bottom, and then back to the top. And then both of those need to have a circulation route, ideally on the same floor to either the NICU or SICU, because that's where, I'll just throw out a number, 90% of all of the deliveries are going to go, the babies will go after delivery. What's optional is on the left side. Sometimes having an MFM outpatient ambulatory clinic out in the region can be better for access for different people. of different socioeconomic conditions or regions. But there is a benefit also to bringing that into this unit. If you do that, we start to talk about a one-stop shop, where you've got the outpatient component, the inpatient component, the perioperative component, all tied together on the same floor. And when you do that, you can take advantage of some synergies, including staffing. So showing administration or administrative suite down there at the bottom left, where in the perfect world, that would be part of it, because if this is especially in a pediatric hospital, these specialists are dedicated to this floor only. They're not going anywhere else typically. So having their offices here, having their outpatient clinic here, having their inpatient clinic here is very effective. And now getting into a little bit of just a kind of a simplified department example, how might you lay this out? You can see the same 4 different compartments we're talking about earlier. And here at the top left, you can see a maternal fetal medicine entry. You might have a dedicated entry into the MFM outpatient clinic because they're coming in for a 1 hour or even an all day 8-hour thing, depending on how many specialists they need to work with. And then just to the right of the MFM entry, you can see the SDU entry with the connection to the NICU. If we pull those away by advancing one animation. Perfect, thank you. We'll start with the MFM side. We're not talking about that really today because it's outpatient, but you can assume that you would have exam rooms for ultrasounds, echoograms. And then also a lot of these conversations are very challenging, very hard, and very drawn out. So having dedicated consult spaces, sometimes called nesting rooms, something that it can accommodate not only the mother in a stressful situation, but everybody else in the family that might be with her is really important. And they may be in this unit for 8 hours. They may have to talk with a lot of specialists, go get an ultrasound, come back at the room, wait, have a specialist come in and talk to them. So just be mindful of that if you're laying out an MFM clinic. Down below to the left, you can see administrative sort of serving as an anchor here in this just simple example. But then in the inpatient and the perioperative components, we wanted to point out that whether your triage rooms are in a dedicated room of their own, or if they take place in the LDRP room, in the perfect world, you have immediate access coming off of, let's say, the elevator or wherever your circulation is coming from to bring the mothers into those spaces to get assessed as rapidly as possible. And then in relationship to that, ideally, the operating rooms are very close to the entry, both to get the mothers to the OR as quickly as possible, but also the baby to the NICU as quickly as possible. So while we have a tendency to bury the operating and perioperative suite in the back, where cross circulation isn't a concern, we always want to be mindful of, is there a better strategy to bring that up front while still not bifurcating the department? And then we wanted to point out on this slide that it's always possible that you have a need or an emergency where 2 ORs would be beneficial. Most of these cases are going to be scheduled, but you could always have a complication arise for somebody who's staying in an inpatient room or an emergency walk-in. And having a backup room is priceless. So we always encourage institutes to consider that if possible. And then in this case, we're showing an infant resuscitation space shared between the 2. So you could theoretically have 2 mothers delivering at the same time, and both of them could bring the newly born infant into the infant resuscitation before going off to the NICU.
Okay, so that was a great walkthrough of really kind of an introduction to the SDU. We're going to go through Connecticut Children's as an example in just a minute, but we've done a number of these projects, and there are a couple things that are really kind of common throughout each of these that we've seen. The first most common thing, and I guess I put this on the slide, is that every single one has been pretty unique. So it's really based on institution, it's based on location, population, there's a lot that goes into it. But we wanted to talk about a couple things, including the fact that experience is really critical. So Hanson just talked about, like, you know, you may be there for the full day, how you enter the outpatient component, how you enter the inpatient component matters. But again, we're talking about an adult, essentially an adult facility that's being inserted into a pediatric campus. So thinking about mom, thinking about the fact that, you know, while we hope that positive outcomes will always be reached, they're not always reached. So what is that experience like for the patient? What is that experience like for the family? How does that transition up to a NICU if the baby is in NICU? These are all really important things, as well as considering, you know, separate entries or a dedicated entry, even just thinking about how does a mom in labor arrive to the facility? So, you know, labor happens at all times of day. So you may show up at 3 in the morning and The only door that's open to the pediatric hospital may be in the emergency department. So is that the ideal place for mom to go? That again varies based on each facility. So you really have to talk through all of those unique challenges in this instance. So again, I mean, I just talked about connectivity and where people arrive. Connection back to things like NICU is also really critical, just so you know, mom can go see baby if she's able, but also you have a quick route to get the infant up to the NICU or across the NICU, wherever that connection happens, for the safety of the infant. And then adult partnerships, Hampton mentioned this as well. So again, traditionally you're working within a pediatric environment. So having an adult partner involved so that they can care for mom is a big part of it. And what we've seen is that traditionally those conversations maybe happen a little bit too late. It's really complex getting that partnership on board. What does that look like operationally? What does that look like in terms of from a financial perspective, from a design perspective? It all goes into play. So the sooner that can happen, the better, but also building the right partnership, I think, is a really critical part of that. You go ahead, Cindy. Other challenges, operational models. So as I said, it's all very unique, even within each facility. So defining what that's going to look like, how you want to operate, because you're not going to be within a typical planning unit from a code perspective either. So building a relationship with the AHJ is really important. Having that person as a part of your team. Because in a traditional unit, you know, it's set line items of what you have to have. You might have a variance for one item or two items based on your operations. But in this instance, it's really a very different experience. So we've highlighted a couple here, but you know, we talked about the well baby area within a traditional LDR or LDRP. So that's somewhere that's code required in the obstetrical unit, and it is where you can take baby who is healthy. Well, these babies typically aren't able to go into well baby. They're typically going to the NICU. Hampton did mention there's a slight possibility you could go back into the room with mom, but what we didn't really cover is the instance of multiples. So sometimes you may have twins or triplets where one baby may be healthy and maybe one baby needs intervention. So how do you deal with that? Because ideally you bring the healthy baby back in with mom, treat it like a postpartum room or an LDRP model versus the other infant is going up to NICU. So when you have that type of a situation, you would also want to consider things like infant bathing, circumcision, location of the infant head wall. So in a typical LDR, that infant head wall is going to help to provide minimal intervention kind of after birth for the infant or to do those first checks, et cetera. But in this instance, baby might be staying in the room, or you might be even going into, say, couplet care where you've got a NICU infant, maybe a lower level of intervention needed, but again, you're trying to get them back with mom. So having opportunities to have those conversations and really talk through what is the operational model, how do you deal with that differently? You know, do you have dedicated triage rooms? Do you do that within an LDRP room? Do you have dedicated antepartum rooms, or do you do that, again, within one shared room? So these are all things that really matter. Speaking of antepartum within those rooms, length of stay is really critical. So in these units, you don't typically have as many LDRP rooms or as many patient rooms for moms. So considering what type of interventions are being done, how long, what your population is, how many rooms do you need? I think Carrie's going to touch on this later probably, but one thing that we found when we did tours for Connecticut Children's was that every single unit that was toured was already under construction actively. So there's never enough space. That was the feedback we've been given consistently. There's never enough space. And part of that is what Hampton mentioned of just having all of these different components, and you're really trying to create one large one-stop shop. So how do you make the most out of the space that you have, but very important to consider as we move forward. With that, I'm going to turn it over to Carrie and Cindy, who are going to walk us through the example of Connecticut Children's.
Carrie, do you want to take this one away, or?
Go ahead, Cindy. You can
Okay.
kick us off.
All right, so we, a group of us here, we partnered with Carrie to design this brand new tower at Connecticut Children's, and this is the rendering. It's under construction now. I'll get into the exterior a little bit, but let's, the reason why we brought an SDU, and Carrie, I think this one you can.
Yeah. So I can jump in here a little bit. So, and just to give you guys a little bit of context. So, I think Cindy mentioned this at the beginning, but I've recently joined Canon Design, and I'm heading up the global practice for pediatrics and women's health now with Canon Design. But I just recently transitioned from an internal role with Connecticut Children's, and I was serving as the Senior Director of Facilities during design while this project was going through both the strategic master planning process as well as the programming and schematic, and then, you know, design development, and then through the kind of first half of construction. So the interesting thing about a program like, you know, a maternal fetal, I can't find my words today, slash SDU, what, you know, whatever words you want to use to describe it, is that it's really a very niche program in all sense of the word. And so there's not a lot of data out there in terms of benchmarking. There's not an SG2 guide that tells you here's what you need for the population in your area. But what Connecticut Children's knew for certain is that if you do look at the population in the Northeast in general, we have declining pediatric rates in the Northeast. We're not growing as a kind of population base. And this kind of touches on some of those metrics that you heard from Gary early on in the presentation. We're seeing, you know, birth rates actually decline, but at the same time, we're seeing the age of our maternal population actually advance. And so when you couple those two things together, you're actually getting much more acute issues when it comes to birthing conditions. And so those two things require much more intense solutions when it comes to pediatrics. So what that drove Connecticut Children's to do during that master planning phase was to look at both the quantity and location of their NICU beds. That was the main driver of the tower itself. But then also what else is driving the NICU population? And so maternal fetal medicine came about as part of that conversation of, well, clearly this is going to be a market that is growing, and that is considered what is kind of known in the healthcare world as destination healthcare. In other words, if you build it, they will come. So if you have the right program and of course the right physician in place, people will seek out this type of program, and they will travel great lengths to get there. And so you solve for the low birth rate, or, you know, the declining population, by looking outside the borders of the Northeast, outside the borders of the state of Connecticut. So those, you know, kind of strategy conversations happened very early on, and it led them to really think aggressively about, you know, let's get the best fetal surgeon in the world and build this program. And so it was decided they were going to build a fetal care program. And this is a photo of Timothy Crumbleholm, who they did successfully recruit for this program. He came on board. Actually, I want to say that he actually started during our design development phase of this project. And he was kind enough to kind of take part in a few meetings before he was technically on board with us, I think, but we did make a few decisions before he was officially on board. And so that was an interesting time frame as well, because there was there's some conversations of, are we building for an individual, or are we building for what's best for the program? So, you know, there's lots of kind of operational questions that go into benchmarking and planning and all of those things. But in any event, just, you know, the history of the why and what leads you to build a program like this is interesting to me as well. So You can go ahead, Cindy. So just context on the tower itself, the addition. I mentioned that the NICU was the main driver of this expansion. It's about 195,000 square feet, 8 stories. So it's matching the number of stories of the existing tower. And it's going to have 76 new beds. One of the floors of that tower is shelved for future growth, but there's going to be 2 floors of NICU, so 50 beds of NICU. One of the floors is split between acuity adaptable and advanced cellular gene therapy, which is bone marrow for all intents and purposes, but it's also opened up for other gene and cellular therapy methodologies, including MIBG and some other stem cell-based therapies that are still in kind of that research-based phase. And then there's an entire floor in this new tower that is dedicated to that maternal fetal care center. And obviously that's the focus of this program, which is comprised of 6 LDRPs. We have 2 ORs. One of them is focused on the fetal OR. One of them is C-section. And then we have an outpatient program that supports this, that is aligned with that inpatient program. And we'll go into a little bit of that component as well. So just a half a step back to kind of share with you that we did a roadshow of the entire country. You know, everybody was really, really interested in what has been done. What did they do well? What did they not do well? What did they miss? What should we replicate? But what should we do better? And so we partnered with Canon Design and, you know, every children's hospital that would answer our phone call, essentially, that had a fetal program across the country, and asked them if we could come visit, asked them if we could interview their clinicians, asked them if we could tour virtually or in person. And so we did a combination of both on-site and virtual visits with multiple programs, some of which Dr. Crumbleholm, who I had mentioned before, had actually personally been involved with building the programs for. And what was interesting about those visits, and Colette actually had mentioned this, is that every single one that we visited in person was actively under construction. And so all of them, without a doubt, had said to us, whatever you think you need for space, build more. And that actually blew our minds, because we thought that this was going to be such a, you know, such a niche program, such a kind of small blip on the radar, that there was no way in our wildest dreams that all of our rooms would ever be filled in a 10-year period. And yet here we are visiting 4 different centers who said the exact same thing in their planning phase, that there's no way that all of their rooms would ever be filled. And they were all under construction to build more space. So it actually caused us to look at our planning a little bit differently, and to change the types of rooms we were building, and also to plan for future growth as we looked at some of the softer spaces that could unplug more easily from the program.
Another benchmark tour note that came out of all the tours is that I saw in the notes that a lot of comments were create a separate experience for mothers. A lot of them had, you know, they felt like they really needed to be separate from the pediatric side, and have a dedicated entry point, have a dedicated reception, and circulation into the floor plate. So we took that and we listened and we studied as we did the design of the building. We worked closely with the design team. There's going to be a new garage planned across the street from the new tower on Washington Street. And we designed a new bridge that would connect to the tower. Advance. So mothers who are parking in the garage can come across that bridge and enter this dedicated elevator specifically for maternal fetal care center. They would come across on floor 4, and then they would go down to floor 3 that had the maternal fetal care center. Conversely, if they were being dropped off, they could come into the main lobby on floor 2 and go up the elevator to the maternal fetal care center floor. This is level 2, the main entry floor. There's a really nice double height lobby and a cafeteria on this floor. This is the main drop off. They enter through the vestibule, would check in. If they're a mother or a family member of a mother that needs to come up to this floor, this is the dedicated elevator for MFCC. If you are a family of a pediatric patient that needs to get into any of the other units, this is the existing hospital elevator bank with public and service elevators. The public pediatric in light blue, so they would be directed to use those elevators to go up and connect. On level 4, as I mentioned, the garage across the Washington Street, families or mothers would come across that bridge. They would be kind of stop at the reception security desk and then be directed to that pink elevator for MFCC and go down a level. This floor housed a pharmacy, a large new pharmacy and conference center. And you can see a curved outdoor terrace out here that could be accessed by the public and staff. Okay, and if you need to go to the rest of the existing units or the new units for pediatric, you would be directed to those elevators over there. So we really thought about the entry point, creating a very separate and entry experience for moms and families. So this is the maternal fetal care center on level 3. They would come up the elevator, be greeted at a reception. If they needed to get an outpatient ultrasound or echo, they would wait and then be brought into any of these 3 echo ultrasound rooms. One is an echo, the other 2 are just exam ultrasound.
There are actually, we intentionally designed 2 nesting rooms directly off of that waiting room. And so nesting rooms are a lovely way of describing a long-term waiting room. But if you think about it, again, I mentioned destination healthcare. Many of these patients will travel very long distances for these types of appointments, and they will combine these appointments in really long days worth of scans and consults and back to back to back. Sometimes there will be gaps in between those consults. And so what they like to do is set them up in this room that they call home for the day. So they get a nesting room. Their partner or family member that they are traveling with could stay in that room while they are going back and forth between those appointments. There's, comfortable seating. There's a under-counter refrigerator with, beverages for them, a spot for them to set up their laptop if they want to try and get work done. But the intention is for them to kind of have a kind of makeshift hotel room, if you will, that's obviously not meant for sleeping, but it's meant for kind of a comfortable stay for kind of longer than a traditional waiting room stay. So those nesting rooms are really meant to set those patients up for that outpatient program so that they have somewhere to go back to that's not generically out in that waiting room in between all of those appointment types. Sorry to interrupt, Cindy.
No, that was a good point. And if they need to go into the inpatient unit, they would be brought in that direction and into any of these 6 LDRP rooms.
Yeah, and sorry, I'm gonna just kind of interject here with one more thing. This is another example of one of those things that we learned during benchmarking visits. So I had mentioned that concept of whatever you think you need, build bigger. We had started this project with the intention of building 4 LDRP rooms and 2 triage rooms. After hearing what we heard on those benchmarking visits, we had decided to change that logic and build 6 fully operational LDRP rooms with the intention of using those first 2 LDRP rooms as triage day 1, but with the ability to flip them into full LDRP room use without any renovations down the road. It's just an operational change. So the intention there is just simply that the volumes wouldn't be there day 1, but we're going to just invest the money day 1 to put the infrastructure in and build the square footage necessary, that they wouldn't simply be triage rooms, but they would operate as full LDRP if and when it became necessary from a volume perspective.
And then this, oh, sorry, this is the large fetal OR down here. Let's see if my arrow works next. That might disappear. And that's a C-section OR up there. There's a room in between for 3 infant resuscitation, a small, very small clean core behind them to supply sterile supplies. And then the rest of the operating suite has a plethora of support rooms. A new one that we created was for a Da Vinci robot, because they want to be able to use the Da Vinci robot in the fetal OR room.
Yeah, that was a fun change that came about actually during construction just a couple of weeks ago. So, you know, talking about, you know, things that pop up and change and, you know, get modified. And this comes about when you figure out your adult partnerships too, you know, figuring out what equipment you're going to be using in these ORs. And sometimes it's a foundation aspect too. So Foundation was able to get a grant, and that grant came with a Da Vinci robot. And now we need a space to store that Da Vinci robot. And they're substantial in their footprint. So, you know, those things come with a cost when you're already building walls. So just, you know, things to think about during your planning and making sure that you're asking the right questions of, even if it's not in the budget now, do you think you ever might have one or want to have one? Because having the foresight early on in the planning will really save you a lot of headaches down the road. And I just wanted to also point out that there is really a substantial difference in the square footage of those 2 ORs. So I think it was Hampton that had pointed it out, but you know, that lower OR can and will have up to 30 care providers in that room at any given time during a fetal procedure. So there's a whole care team that's for mom, and then there's a whole care team that is for the fetus. And when you think about the amount of bodies that have to fill that space for those 2 different patient types, the different amounts of equipment that have to go into that space, the different amounts of ventilation and airflow that have to serve that space for that many bodies, it's substantial. So there's a lot of coordination just in that one room alone.
That's a good point, the equipment. And each of the 6 LDRPs were designed same-handed. And we have provided equipment rooms. They're, you know, they were initially alcoves, but they both have slider doors in and out of the room. So the equipment for birthing and delivery are housed in that room, can be brought right in. So it's not clogging up the room. So we were thinking about the mother's experience as well.
Yeah, that mother's experience was a huge part of what drove the design for these LDRPs. One of the big factors there was the scariness factor. If you're a mom and you are in this unit, you are not thrilled about being in this unit, right? You are terrified.
Yeah.
You are here because there's a very real possibility that your unborn child needs some type of surgical intervention, and that your child may or may not survive outside the womb. And those thoughts racing through your head while you're sitting in an LDRP room are not welcome, right? So the last thing we want is for mom to be staring at a really scary medical head wall while she's on bed rest at 20 weeks. So we were really intentional with the infant head walls to have, millwork panels that were gracefully covering up all of those scary looking medical devices. Even on the mom's head wall, we're covering up all of the unnecessary devices so that she doesn't have to look at them, especially for those bed rest conditions where she may be in that room for a very long period of time. And we don't want her thinking about all of those unknown scary conditions while she's got nothing better to do than look at all of those devices and wonder what they're actually going to be doing with all of them.
And before you, or maybe as you leave that slide, Cindy and Carrie, one of the guests asked about cesarean section recovery track, and just, is that happening in the LDRP room?
Yeah, so the cesareans are going to be happening in that second OR. And that OR is actually going to be always dedicated and open for emergency C-sections. So scheduled procedures are always happening in the bottom room, and the top OR is always held as an open OR for those emergency conditions. So that was an intentional design so that there would always be that second opportunity just in case. This is not the case for every fetal unit. A lot of fetal units will build only one OR because you're only technically required to have one that can perform a C-section. But that was the directional strategy that they decided to go in from an operational perspective so that they would always have that flexibility. For the most part, the C-sections that are scheduled will still happen in the fetal OR, I believe, in the lower left-hand OR, in the larger one, because then they would also have Dr. Cromelholm involved for the fetal intervention as well, in theory.
One more question is, how do they deal with a patient who may come in early on an emergent basis for their CS, but the unit is at capacity?
So this is all about the adult partnership, right? And this is tricky. One of the things, and I will be transparent here, that is not fully worked out even with this unit is, what do you do with a mom presenting in labor? The Children's Hospital current state is not prepared to receive a mom in labor. That is not something they do today. If a mom presents to the front door in labor, technically EMTALA says you have to treat that mom in labor. So we have had this situation in the past because we actually sit on a campus that is shared with an adult hospital. Connecticut Children's sits on a campus that's shared with an adult hospital in its current state. So when a mom presents at that emergency department for the Children's Hospital by mistake, the emergency department actually has to triage her and stabilize her and then transport her. That's like the EMTALA rule, because you can't just turn them away. Because something in theory could happen if she walks herself to another emergency room, even though it's literally 30 feet away to the other front door. So there's a lot to be worked out operationally of what happens if a mom in labor shows up at the Children's Hospital instead of the adult hospital. Because in this case, where the addition is being built, it's clear on the other side of the adult hospital. I think the model in the long run is going to remain all active labor goes through the adult hospital emergency department and triage system, because the children's hospital is still not set up in a way that accepts active labor patients. Hampton put it really well in his portion of the presentation. This type of unit is specialized in taking care of well moms and unwell fetuses. If we open the doors for children's hospitals to take any mom in labor, there's kind of no telling who shows up, right? So by keeping them through the adult hospital system's front door, they can appropriately triage who should and shouldn't be coming to this unit. The flip side of that is that they're, generally speaking, a very kind of scheduled and intentional patient population for this type of unit. It's very rare that they're coming through in an emergency. It could happen. It's not unheard of, which is why they wanted an emergency C-section OR, but they think that it's much more likely that it's a, they've got 3 rooms with moms on bed rest from, an 18-week period. And then they'll have the other 3 rooms open for moms that get sent over from the adult hospital. I hope that answered the question.
We actually have a few more slides, but I think we talked through a lot of it already. This is the kind of the zone blocking of the floor plate. You can see the inpatient unit, the perioperative suite, the family lounge with the nesting part of it, outpatient, and the admin suite. And Carrie talked about really studying how to create expansion.
Yeah, so one of the things that we were really concerned about was how do we grow? We're completely landlocked here. So I had mentioned that this hospital, actually, it's sitting on an adult campus. It's actually more complicated than that. It's sitting on land that is a land lease with the adult hospital. So the external expansion of this hospital needs the permission of the adult hospital to do it. So this is kind of this is it. This is as far as they can go in terms of the expansion capability. They're completely landlocked. They've got existing buildings on all 3 sides now. So there's nowhere else to go if they wanted that fetal expansion to happen on this level. So what was identified in terms of exterior window space, because that's what you need for inpatient rooms, is that there's what we lovingly call the knuckle of the building. That's where the expansion and the existing building come together. There is exterior window space there. And so we had identified during the planning phase that if we unplugged that soft administrative space, there was room, in fact, for expansion there. And I'm not sure, Cindy, if we dropped that slide in or not.
It's ghosted on the bottom. It was just, It was very early, sketchy with bubbles. So.
Right. So we were able to identify that we could, in fact, get 2 additional inpatient rooms in that area within that expansion zone. Whether or not we even kept that green outpatient area intact was another question, because we could also unplug that area in order to expand the inpatient function, because in theory, you don't, Hampton had identified this in his graph as well with his dotted line and solid line. You don't need your outpatient program directly adjacent to your inpatient. So we could, in theory, unplug that one as well. So those 2 areas were identified as the first 2 areas to unplug for growth, so that we could, in theory, expand the inpatient program without disrupting the operations of the ongoing inpatient program if they needed to in the future. And one last note about this. One of the other things that is really significant about this type of program is what's known as the halo effect. And this is something that was planned for in the numbers when it came to the initial planning and programming of the master plan and the number of NICU beds that drove the tower in the first place. However, in the benchmarking visits we took, it seems that the halo effect can be even greater than initially thought of. So in layman's terms, what the halo effect is that if I'm a mom who has been sent to or sought out Dr. Crumblehome for his exceptional care because there's a potential that my unborn child may need fetal intervention, and he goes through the consult process, I get all of the scans, I get the complete workup, and it was determined after I saw him that my child actually does not need fetal intervention, but I still am very, very reassured that his expertise lives at this hospital, that his care team is here at Connecticut Children's, and that there is a kind of a whole team of experts that know how to deal with the condition that my unborn child has. And so if there's complications associated with the birth of my child, wouldn't I want the top experts in the world there at my disposal to make sure that my child has everything that he or she needs? So that's the halo effect. I don't actually need fetal intervention, but I am reassured by the idea that if I needed Dr. Crumblhome's team, I could have it. And so I'm going to choose to deliver my child with this hospital system. And so my baby obviously will need NICU care, even if it doesn't need the fetal intervention portion. And so now our NICU volumes are going to see a dramatic increase as a result of that halo effect. Again, initial volumes accounts for that, but what we're seeing from our benchmarking initial visits is that halo effect is even more drastic and dramatic than we had initially calculated or hoped for in those planning numbers. And so that shell floor is planned for from an infrastructure standpoint and a layout standpoint to accommodate another 25 bed layout of NICU beds, and it's stacked directly below the 2 existing NICU that are being built above. It is intentionally on the 5th floor below the NICU so that we are not overbuilding on top of, operational NICU beds, because of course the noise translation in NICU is a very sensitive area to be building around.
Carrie, in that scenario, I'm assuming the birth would then happen at your adult partner. Is that correct? Or would they
That's
still?
correct.
Okay.
That is correct. Yes, they would not birth in the LDRP unit within the fetal care center. That's correct.
Okay.
Yep.
And I will just share these images are the fetal OR with the infant resus. The C-section is up top, but we went through a lot of work with Dr. Crumblehome to get the layout, get the booms, get the teams in the right spot. Those 30 people have to have good working area, good working zones. So as I worked on this, and I've done some fetal ORs in previous projects, it was very enlightening because he was very specific on how he was very renowned. He only did very specific procedures that no one else could do. So he was very specific on where he wanted the booms, and he didn't want any conflicts or obstacles in his area of work. So it was really interesting to work with him to get this right.
And Cindy, you and the teams did an amazing job also assessing to your point, how do we have dual function within a single set of equipment confinements? So where do we ideally put those booms? So I think y'all highlighted an excellent thought of, it's not just C-section, it's not just vaginal delivery, it's not just fetal intervention, it's all of these things with potential infant surgery in the room as well. So just being mindful of those boom locations is really important.
And one thing that he did unique that I hadn't seen was additional light booms, because even if you had the resus room and this resus zone here, he wanted additional space to do surgery because the mom's in the room and he needs to the baby's out of the womb and something, God forbid, something happens and he has to do OR procedure on the baby that's not unforeseen. He wanted additional light booms in that end zone because that room's almost 900, 800 square feet. It's really big. So he wanted to utilize every square inch. All right. Oh, Carrie, you want to go on this one?
Yeah, so one of the really great things that we were able to do with this project is build full-scale mock-ups. So we rented warehouse space about 5 minutes away from the hospital, and we built out every type of primary care space that we were going to build in this tower. One of those was the LDRP room, including the head wall for mom, but also the head wall for the infant, as well as the bathroom. The bathrooms, believe it or not, were a big topic of conversation for everyone. But we also built out the fetal OR, not the C-section OR, but the fetal OR, because that was the one that we had never done before. The C-section OR, there was enough experience. They felt that they could, pull that in from the adult partners, and that would be, that would be okay to use benchmarking for. But the idea of 30 people in one room, they wanted to build that, and they wanted to see what it felt like, and they wanted to know what the boom placement was going to be like. And so we did that. We built the walls. We put 30 people in the room. Canon was able to build these beautiful 3D renderings that were tied to QR codes. And so anybody that wasn't physically able to visit, and even those that were physically able to visit, were able to hold up their phones, scan that QR code, and kind of, because they were very rough spaces, kind of pan around the room and get a feel for what the equipment and the finishes might look like in its final state. We brought broken equipment from the hospital over so that they could get a sense of, what the room might start to fill up with. And we got everybody from, nursing, anesthesia. We got surgeons. We got central sterile team members. We got a lot of different team members. We even got our EVS team members to come through and talk about how they would flow through the rooms. We got our facilities team to come through and talk about maintenance concerns. We got our IT folks to come through and talk about wireless access points. We really got input from just about every touch point we can think of in the hospital. And these were just invaluable. I think we made a lot of tweaks to the plan as a result of the feedback loops that we got from these mock-ups. Overall, I would say they were just a huge success, and they were really well received by everybody that participated.
Yeah, the feedback was great on that. And then lastly, as part of the design, I talked about the terrace on floor 4. We thought about outdoor space a lot in this building design, and provided as much of it as possible where we could. That was very thoughtfully laid out, maximizing sun exposure. Outside of the building, you have this large open grass area that, Carrie, you were like adamant, like we could do so many multifunctional events out there, have the building behind us. And so I thought you were like the best champion with design eye and the programming and the planning side. So I would say attribute it to you.
I mean, all I have to say is go be a facilities director for like a hot minute in a hospital, and then you will think differently as an architect from that day forward, because the space challenges that you are faced with are like mind-numbing. I'm like, you need what now? And one of the things that I heard constantly in this hospital, because they didn't have enough space for anything, was that they don't have a space, nor should they build a space that can that can accommodate all of the employees at once for some type of team building, you know, all employee engagement event. And they do those, you know, a couple of times a year where they have some type of, like, they do a nursing pinning ceremony. They just had a 25-year anniversary celebration. They do like a summer cookout. So they do these events where it's like all team member events. They don't have a place to get everybody that works in the organization together at the same time. They don't have a way where everybody that works there can even engage if the president of the hospital is, you know, giving a speech in, you know, at a podium on the front lawn. And so one of the thought processes with these different terraces was, wouldn't it be amazing if Jim Schmerling is on the front lawn at the podium giving an address to the media, and the terraces are just lined with people? Because now you can bring everybody that's inside the building to the edge of the building and allow them to hear and participate in what's happening on that lawn, in addition to those that are actually able to go to the front lawn. And so now you're engaging a whole nother audience that you could never engage in the past. So the name of the game was absolutely flexibility. We tried to build in as much flexibility in all of these spaces wherever we could see fit. Even in the LDRP rooms where we have 2 different head walls, those head walls are both built to ICU level capacity, because in my mind, I said, guys, this is great. I want a fetal care program, but what if the fetal care program is a total miss and we need you know, a SICU in 2 years? Could we make this a double room SICU if they needed to flip it in 2 years? And the answer to that was yes. So we built all of the rooms with universal head walls, with the intention that, one, we float our nurse pool quite a bit. So we wanted to make sure that the provider error factor was going to go down, so that you wouldn't be searching for things, and that regardless of the room type that you went in, you were going to have the exact same layout on the patient head wall, no matter what room type you went into. 2, if another COVID pandemic or the next pandemic, whatever we're going to call it, shows up in 2 years and we need ICU level care, we have capacity. And in some cases we have double capacity. We actually even have the room, because we have double head walls in all of our rooms as the standard. We could double up our rooms. It's not FGI compliant in terms of clearances to put 2 beds in every single room. However, during pandemic conditions, they relax those types of requirements, and we could push those boundaries in these rooms if it was necessary, because we did do those things during COVID. I mean, we were treating patients in our conference rooms and cafeteria because that's what we had to do. The conference level in the tower expansion, although it's not planned for as a day 1 use, the mechanical units and the infrastructure are actually sized so that that level could be completely flipped to another patient floor, because it is absolutely in my mind that they are going to ask to do that one day, because I was asked on a consistent basis to flip office space to clinical space in my past life. So those are the types of things that we tried to think about as, you know, throughout the design. And I'm sure that the project, more than I'm sure, the project paid a premium for it, but it was the right premium to pay, because it's always going to be cheaper to build it now than it is to build it 50 years from now when they're out of space and they're trying to retrofit a space that wasn't built for it in the first place.
And that's a wrap.
Thank you so much. That was a really excellent presentation. I really appreciate all of it's a really interesting topic, and I appreciate all of your very thoughtful, wonderful graphics that explained everything in a very simple way. It was very a great presentation, but I know we are at time, but if there are any additional questions, would love to get them from folks, and while we still have people for a few minutes.
Yeah, and if people think of more questions, they can reach out to me. I know a lot of you, but and then I can field it to Carrie and the team here. But Carrie went through amazing amount of detail on operations and planning and design. And thank you so much for being part of the owner side and then joining us and really helping us kind of launch this group upward. So.
Yeah, it was wonderful. And I should say, I would be completely remiss without mentioning that I did have a wonderful, wonderful partner at Connecticut Children's, who is still there. Shannon Grad was my clinical liaison. She is a nurse, and was kind of appointed as the senior clinical liaison / design lead, which was a really interesting position that we were able to create as a partnership within the facilities world, as a counterpart to my role, so that we always had somebody that was clinical adjacent to somebody that was kind of design oriented. And that partnership, I think, internal to the hospital made a huge difference for the relationship that we had with the user groups, because when one of us wasn't communicating in a way that was resonating, we would tag the other one to kind of jump in and say, okay, I need your help on this one. And it was a wonderful kind of way to swap out, because we had very different communication styles. And obviously, nursing, I think, looks to nursing for leadership and kind of reassurance. And so they needed to hear from her that we were doing the right things. And I think it really went a long way in making sure that we had a successful buy-in from the right people.
All right. Well, thank you again for everyone staying a little late after finishing up I'm sure, very busy
Sorry.
days. So this was great. Thank you so much. And thank you to the Canon team for this presentation.
Thank you.
Yeah, absolutely. Thanks, everyone.
Thanks, everybody.
Have a good one.
Take care.
Thanks.